Hello, my name is Dr. John DeWitt, and I am Professor of Medicine in the Division of Gastroenterology and Hepatology at Indiana University Medical Center in Indianapolis, Indiana. And I'm pleased to bring you this GIE author interview series video for a recently published article entitled EUS Pancreatic Function Testing and Dynamic Pancreatic Duct Evaluation for the Diagnosis of Exocrine Pancreatic Insufficiency and Chronic Pancreatitis. The diagnosis of chronic pancreatitis is relatively straightforward when there is advanced disease present on imaging. In patients with minimal change disease, the clinical suspicion is there, but there is no evidence on cross-sectional imaging and perhaps minimal evidence on EUS imaging. Some centers have added pancreatic function testing to the clinical evaluation of these patients. During this test, a hormone is given which stimulates the pancreas, and juice is collected at timed intervals for various substances or markers. One such hormone is secretin, which when given stimulates the pancreas to make bicarbonate, and this can be collected at various intervals to determine whether exocrine pancreatic insufficiency, or EPI, is present or there is normal exocrine function. In this study, we sought to evaluate the impact of pancreatic function testing, specifically secretin-stimulated function testing, on the EUS examination for the clinical suspicion of chronic pancreatitis in patients with suspected minimal change chronic pancreatitis. In addition, we sought to determine whether or not duct compliance or the parenchymal and ductal features following secretin, or the amount of fluid collected from the small intestine, could impact the diagnosis in these patients. So for this disease, we enrolled consecutive patients who had clinical suspicion of chronic pancreatitis without clear evidence of pancreatic disease or evidence of chronic pancreatitis on imaging. EUS examination was first performed, during which parenchymal and ductal features were measured. Then secretin at a dose of 0.2 micrograms per kilogram was given. Following secretin at 4, 8, and 12 minutes, the diameter of the pancreatic duct was remeasured in the head, body, and tail. At 10 minutes, the measurement of the gland in the AP direction was made, and the parenchymal and ductal features were remeasured or reassigned to see if any changes were made following secretin. Finally, at 15 and 30 and 45 minutes following secretin, the duodenal fluid was collected and sent for bicarbonate measurement. Two important definitions we used were: one, EPI, or insufficiency, was diagnosed when all three values at 15, 30, and 45 were less than 80 millimoles per liter of bicarbonate. Second, we diagnosed EUS evidence of chronic pancreatitis by the presence of 5 or more features. So in our study, we enrolled 145 consecutive patients. Of these, 32 had evidence of EPI, and 113 had normal exocrine function. Of these 145, 47 had EUS evidence of chronic pancreatitis, that is 5 or more features, and 98 patients had 4 features or less. Now, there were several important conclusions from our study. First, we concluded that duct compliance, as measured by changes in pancreatic duct measurements in the head, body, and tail following secretin, and the amount of fluid collected following this, did not help in the diagnosis of EPI in our population. Second, we found that the timed measurement at 45 minutes of duodenal bicarbonate was essential to confirm the diagnosis of EPI. Specifically, in 18 patients, the diagnosis of EPI was only made following the 45-minute collection. So we advocate the use of 45 minutes, up to 45 minutes for that collection. Thirdly, we did see some parenchymal and ductal features that changed following secretin administration, specifically in patients with evidence of chronic pancreatitis. Lobularity and duct side branches were present in greater amounts. In those patients who had evidence of EPI or no evidence of EPI, we found that the parenchymal hypercoic foci and stranding became more prominent following secretin administration. The next major conclusion we had was that the diagnosis of EPI had a sensitivity, specificity, and accuracy of 23, 79, and 61% compared to the EUS diagnosis of chronic pancreatitis. This was lower than that seen in other articles, and probably reflects the overdetection of our center for certain features in the parenchyma and duct for consideration of chronic pancreatitis. The final conclusion we had was that the findings of EPFTs had a significant clinical impact on the clinical suspicion of chronic pancreatitis. For example, if patients had EUS evidence of chronic pancreatitis present on EUS examination, then the findings of a normal exocrine function significantly lowered the clinical suspicion of chronic pancreatitis when we were asked to assess that. On the contrary, if patients had a normal EUS examination and then had had evidence of EPIO on examination, the clinical suspicion of chronic pancreatitis dramatically increased. So our study found several novel findings, and certainly this should prompt further research into this field. We also advocate that the use of EUS alone for the diagnosis of minimal change chronic pancreatitis should not be made, and we do advocate for the use of pancreatic function testing to increase or decrease the clinical suspicion of chronic pancreatitis in these patients, given the relatively insensitive nature of EUS for chronic pancreatitis. Further research is needed, perhaps with other hormones or measuring other compounds to aid in this field, and I thank you for your attention.